How best to let doctors know how you'd like to be treated if you're unconscious or not able to express yourself? Some people reckon the most indelible way is by having a do-not-resuscitate tattoo emblazoned on your chest. The idea is when someone goes to do CPR on them, they'll see it and know the person doesn't want to be revived. But will doctors obey the inked command? And how effective are the other options for expressing your end-of-life wishes? Health Report producer James Bullen has had a look.
This story starts 16 years ago.
My husband had just died of mesothelioma, horribly, and I thought, I don't want to die like that.
Jill Elliott is a 78-year-old woman from Fremantle in Western Australia. After her husband's death, she made a rather spontaneous decision to take control of the way she might die.
I was passing a tattoo parlour and I just walked in off the street. It cost me $80 just for DNR tattooed on my chest, but it was well worth it as far as I was concerned.
Jill's is a very curious tattoo. DNR in black, written across her heart, standing for Do Not Resuscitate.
It wasn't a posh salon I went into. Everybody else is getting skulls on their arm. I suppose they saw this little old lady walk in and think, what the hell does she want?
But her friends and family, they thought it was great.
Everybody at the time said, oh, what a wonderful idea to have your own choice, but no one will have it done because they think it's painful. It's not.
Although it was a spur-of-the-moment decision to go under the needle, Jill feels strongly about the tattoo and her right to choose not to be resuscitated.
This is my body, my decision, not a politician's or a religious leader or anybody else. It is my decision. And who has the right to tell me that I'm not allowed to die how I want to?
But do emergency responders and doctors really follow Do Not Resuscitate tattoos when they come across one? Late last year, the New England Journal of Medicine reported a peculiar case.
I was the attending physician in the medical intensive care unit at our hospital. We got a call to come evaluate a patient in the emergency room who was unconscious.
Dr. Greg Holt is Assistant Professor of Pulmonary Critical Care at the University of Miami.
We take the gown down to examine him, and here is this tattoo that says, Do Not Resuscitate. The knot is underlined, and his signature is, at least what we presumed was his signature, is right there on underneath the resuscitation word. And your first reaction to this was, wow, I thought this was an urban legend. Like, we have always joked around about that in medicine. After somebody has a cardiac arrest, somebody will always say, boy, I never want this to happen to me. I'm going to tattoo DNR in my chest. But you never thought you'd see one, and now I'm looking at one. And at first, there was sort of that shock and surprise and, wow, look at this, which quickly became into, wow, now I actually need to deal with this DNR tattoo in the setting of a patient who otherwise needs resuscitation, which is exactly against what his tattoo is telling us to do.
So Dr. Holt decided to buy some time.
Maybe we can identify him, maybe we can identify some surrogate, or can we think through a DNR tattoo? And so we put him on intravenous fluids. I gave him a medication to increase his blood pressure. We gave him antibiotics. And I put him on a bi-level positive airway pressure. It's a pretty tight mask on the face that helps to ventilate for the patient. And it's one procedure short of putting the tube down his throat, which a lot of people consider full resuscitative efforts. So you might call it resuscitation light while we start to figure out what to do.
You didn't want to take that final step because of the tattoo?
Yeah, because the initial thought was, is this truly his declaration of his end-of-life wishes? And so, in other words, is he truly telling us that he would like for us to withhold life-sustaining therapy? First off, is it a real declaration? And the second off, is this legal? Can I accept this as a legal declaration of his wishes to withhold life-sustaining therapy? I have no idea. So we call it ethics. And ethics was spot on brilliant. Our ethics consultation came down, they evaluated the case, goes through everything that we have on the patient, and he comes to the conclusion that it is most likely that this is his true wishes to withhold life-sustaining therapy. And so using all of the available evidence that we have on this patient at that point, we're going to honor his DNR tattoo, and the man dies probably about, I'd say, 24 hours after he presents to the emergency room.
The hospital later confirmed that this was in fact what the man had wanted.
It's probably about 4 to 6 hours after the ethics consult has told us that we should probably abide by the DNR tattoo. Our social worker tracks down who this person is, I think through their fingerprints. They track him down to his home, find that he has this legal form in Florida that states that he wanted to be do-not-resuscitate. It corroborated perfectly our ethics consult, and we all felt better from that.
But how would this situation play out in Australia? And what would happen if he got it wrong? For one thing, it's unlikely an ethicist would be called in to help.
A lot of Australian hospitals would have treatment ethics committees, as they're often called, but they will often reflect on cases and formulate policy rather than provide an ethicist on call like in the United States.
Professor Ian Olver, an oncologist and bioethicist at the University of South Australia. So, given Australia doesn't have ethicists on call, how's a treating doctor supposed to approach cases like this?
Under, say, common law, the doctor would be expected to satisfy themselves about three things. One is, was the patient competent when they issued whatever instruction about treatment, but a DNR? Was it an informed choice, that they weren't coerced and they had all the information necessary? And particularly, perhaps the most difficult one, did it apply to the situation that the patient is now in? Was that what they meant by it?
Then there's the question of whether the person meant it when they got the tattoo in the first place, or whether they changed their mind after they got the tattoo. Dr. Greg Holt from the University of Miami again.
There was a man who, I think it was in 2012, he presents to an emergency room, and on his chest is the initials DNR. Well, this man actually was awake and alert, and so they asked him about it. And the two things he said is, number one, that DNR tattoo was a joke. He had lost a bet with his medical buddies, and because he lost it while drunk, he had to have DNR tattooed across his chest, and he just did it. But it wasn't actually what he wanted. He actually wanted to be the opposite, which is full code. So the DNR tattoo at that point did not reflect his true wishes. And the second thing he said, which I thought was kind of interesting, was he never thought anybody would take it seriously, like a DNR tattoo. And I think the point that it gets across here is there's not one universal consideration for what a tattoo means.
A more formal method of letting people know your end-of-life wishes is something called advanced care planning. Usually it's a form you fill out with details about things like whether you want to be resuscitated, if you'd like to go to palliative care, and who you'd like to make decisions for you if you can't make your own. Dr. Karen Dettering is the Medical Director of Advanced Care Planning Australia.
So the first thing that can be done is that we encourage people to choose and to appoint a substitute decision maker, which is somebody that would be able to make medical treatment decisions on behalf of the person if they couldn't make decisions for themselves. The second thing that we encourage people to do is think about what's important to them, what they'd like to happen, and perhaps what they wouldn't like to happen broadly, particularly around outcomes. So what would they want to do if it was likely that having treatment would mean they might have a high chance of being increasingly disabled and perhaps not being able to live at home, but then they would also be alive, versus not having treatment and perhaps dying, but potentially not being put in a circumstance where they were incredibly disabled and living a life that they wouldn't necessarily choose to have. And so we encourage them to talk about their goals, their values and outcomes. The third thing that people can do is actually write down specific preferences regarding treatments, so things they would want to have or things that they wouldn't want to have. And the types of things that people might write down are things like that they wouldn't want to have cardiopulmonary resuscitation, or they wouldn't want to have tube feeding, for example, either at all or under particular circumstances.
There's no national scheme for advanced care planning. Every state is different. But Dr. Dettering says the critical thing is whether you've written out a plan and whether your relatives and caregivers know about it.
Often people get a little bit lost in whether it's legally binding, but when we're making decisions on behalf of somebody who can't make their own decision, what we're trying to do is make the decision that we believe that person would make. So if they've written an advanced care directive and we have access to that, whether it's actually technically legally binding in the particular state where the person's getting treatment, it would certainly be very valuable and would likely guide treatment.
And what happens if a patient has an advanced care directive but the family might have different ideas or want to contradict the advanced care directive, or perhaps they don't have knowledge of it for whatever reason.
What an advanced care directive is about the person and how they want to be treated. And if it's well structured and documented appropriately, then it would be upheld and the family wouldn't be able to override it. One way to get around this is we strongly encourage, and in fact the study that we did a number of years ago on advanced care planning, we included family and other key people in the conversations, and we actually found we got much better outcomes when there's open conversation. So if somebody's going to do advanced care planning, we strongly encourage them to talk to their family, to talk to their friends, to the people that are important to them or that might be called on to make decisions, and to do it over a period of time so that people understand.
When there is that sort of collaborative approach, research has found everybody benefits.
It's great for the person themselves because they're much more likely to receive care in the way that they would have chosen if they could speak for themselves. But for family, I mean, obviously making decisions when a loved one's really unwell is hard, but at least making decisions that we believe the person would actually make for themselves is very empowering and reduces the stress and anxiety. It's also great for the healthcare team because as a doctor, I find it incredibly difficult to be making decisions on behalf of somebody else when I don't actually know what they would have wanted.
A few months ago, Jill Elliott went and got an advanced care directive made with a doctor after he told her that other doctors might ignore her DNR tattoo.
I said, well, what can I do? He said, all you can do is to sign a medical directive. I had to take that back then to the surgery. He initialed everything and then he sent it back to the hospital.
Professor Olver agrees an advanced care directive is far superior to a tattoo.
A document that's been crafted, perhaps with a lawyer involved and signed and so on, is likely to be done by someone competent who knew what they were doing and can specify exactly what they mean by it. The problem with the tattoo is it just provides a sort of an early evidence that that's what the patient wanted. It alerts people to not go ahead without considering those things, but it may not provide enough detail. And if there's sufficient doubt, then the doctor's in a real situation, particularly if they feel that treatment will reverse the situation the patient's in.
That's where Dr. Holt found himself, and he's still undecided about the value of such tattoos.
Part of me says what it really did was cause more confusion than clarity, because our first initial impression was, whoa, is this real, is this not real, and made us really contemplate the veracity of it and really push to find this person's documentation at home. But then you have to think, this is what the man really wanted. So, in fact, it actually really did work, because I don't know if someone would have gone through his house trying to find his Do-not-resuscitate document if he didn't have such a tattoo. And so I think it was both good and bad at the same time. It caused a bunch of confusion, but in the end, we abided by the man's wishes.
And what about Jill? Is she worried that her DNR tattoo is too ambiguous, or that it might be ignored?
At the moment, DNR doesn't mean much to people. That's probably why people don't get it done. It doesn't mean anything. It could be my initials, couldn't it? DNR. So I'm going to have it fully done so that when people strip my clothes off, they'll see do not resuscitate written there instead of just DNR. It'll give them a hint that I don't want to be here, won't it? They've got no right to tell me when I'm unconscious whether I should live or die. I'm a lonely old lady now. Why the hell would I want anybody dictating my life?
Jill Elliott ending that special feature on DNR tattoos made by Health Report's producer James Bullen.